Hi, everyone. Good morning. We're going to get started. Today, I have the pleasure of introducing Dr. Llovet. Josep M. Llovet is Director of the Liver Cancer Program and Professor of Medicine here at Mount Sinai. He is also Professor of Medicine, Hepatic Oncology at the University of Barcelona, and Professor of Research in the Liver Unit at the Hospital Clinic of Barcelona. Dr. Llovet was the founder and former president of the International Liver Cancer Association. He has chaired and contributed to the development of more than 10 guidelines related to clinical management and clinical trial design in liver cancer. He has published more than 359 manuscripts in peer-reviewed journals and more than 55 book chapters. Dr. Llovet has devoted his career to studying the pathogenesis and treatment of liver cancer and has received numerous awards, including the American Association for Cancer Research, the Landon International Award in 2009, and the International Hans Popper Award in 2012. Please join me in giving Dr. Llovet a warm welcome.
Thank you very much for this nice introduction. So I'm Josep Llovet. So I'm professor of medicine at the Division of Liver Disease and co-director of liver cancer program at the TCI. And I'm going to talk today about immunotherapies for the management of hepatocellular carcinoma. These are my disclosures. So this is the outline of my presentation. We'll talk about epidemiology, molecular drivers, and precision oncology in HCC, management of early intermediate HCC, and then in advance, we'll talk about molecular and immune therapies, and finally, biomarkers of response to immunotherapies. So as you know, liver cancer is the 6th most common cancer globally and the 3rd cause of cancer-related death. In 2018, we had 850,000 new cases, but by this year, 2025, we're expecting around 1 million cases, mostly in Southeast Asia and Sub-Saharan Africa. In the US, we have around 41,000 cases, in Europe, 68,000. And liver cancer is currently the leading cause of death in cirrhotic patients that represent 1% of the human population. So we are lucky in the fact that we know most of the risk factors that are linking the actual factor to the development of the disease. Number one is hepatitis B virus that accounts for around 50% of HCCs globally. There are around 400 million people infected with hepatitis B virus infection that integrates into the DNA and produces overexpression of oncogenes or downregulation of tumor suppressors. The second cause still is hepatitis C virus infection, although it's clearly decreasing with all the drugs, the DAAs, that actually are able to solve the disease in 95% of the cases and cure the disease, but still remains as a second cause globally. The third is alcohol, that it's flat, so accounts for 15 to 20% of the cases, and is underrepresented in most of the statistics. It's well described, for instance, in Central Europe, in rural areas. For instance, in France, accounts for 60% of HCCs. Then the fastest growing etiology is MASLD, that, as you know, is associated with overweight, that accounts for close to 50% of the population in the US, and associated to diabetes. And this is the fastest growing cause of hepatocellular carcinoma. Then we have cofactors. Cofactors means that there are factors that per se do not produce HCC, but on top of the other factors that I have described increase the likelihood of developing HCC. And this, the most important one is aflatoxin 1, is a toxin that produces a point mutation in p53 that on top of hepatitis B virus infection increases the incidence of HCC threefold compared to the patient with hepatitis B virus infection. Well, let's talk a bit about molecular drivers and precision oncology. So these slides summarize the molecular pathogenesis of the disease in one shot. So you can see that 80% of HCCs develop in a patient with underlying cirrhosis. and only 20% develop in patients with chronic hepatitis. Mostly those patients with muscle D or hepatitis B virus are more prone to have HCC develop in non-cirrhotic livers. Otherwise, most of the HCCs develop in cirrhotic livers. And then there are some molecular aberrations called gatekeepers that do not suffice to develop the tumor, but open the gates for the increase in the proliferation and proliferative advantage to hepatocytes. And these gatekeepers that are currently described are TER promoter mutations, chromosomal gains and losses, and epigenetic changes. And then at one time point, there is an accumulation of alterations, mostly mutations. The most important ones are TERK, beta-catenin, and p53. And there is a point where it's the tumor-initiated event. And from here, you have early and progressed and advanced tumors, and then additional genomic hits occur, mutations, DNA amplifications, deletions, and DNA methylation of promoter regions. So in average, HCC has around 60 mutations per tumor as opposed to highly mutated tumors like melanoma or lung cancer or MSI, colorectal cancer that may have 150 non-somatic mutations, non-synchronic somatic mutations per tumor, as opposed to liquid tumors or pediatric tumors that have an average of 10 mutations per tumor. But out of these 60, most of the mutations are passenger, only a few proportion are actually driver mutations. And unfortunately, among the driver mutations, and this is a study we published in 2015 with Jessica Zuckman, was the first study in the Western world assessing whole exome sequencing in 250 patients, and the most prevalent mutations, TERK, beta-catenin, TP53, ARID1, were unfortunately undruggable mutations. And this is very important. This is by chance. And it's very important because this is the main reason why do not have at this point precision oncology in HCC, because the mutations, the most important mutations, are undruggable. So the ones that are druggable are this long tail of 5% of mutations at BRAF and all this stuff that are very difficult to target in the setting of a clinical trial. So you are very familiar about precision oncology, the oncogenic addiction loops, the BCR-ABL fusion. It was described in the 60s, and imatinib was approved 40 years later. HER2 amplification in breast cancer, trastuzumab was approved 13 years later. Then you have BRAF mutations in melanoma, and 8 years later, bemurafenib was approved. And now we have the example of ALK fusions in non-small cell lung cancer, and crizotinib in a very short period of time was developed and approved. And this is because of the path of accelerated approval in oncology by FDA. For instance, this is an example that epitomizes what's accelerated approval. 1,500 patients were screened. Only 3% of the patients with non-small cell lung cancer have ALK fusions, so 82 were included actually in the phase 2 proof of concept study. And then they have a signal of efficacy, published that in New England, got accelerated approval because of this 6-month progression-free of 72%, as opposed to 27% in historic controls. And then they had accelerated approval pending the phase 3 confirmatory study when they enrich the trial for ALK fusions, and they randomized the patients crizotinib versus the chemotherapy, and 0.49 was the hazard ratio. So this is the final slide for introduction. So in terms of mutational landscape, this is a study running Memorial, 10,000 patients, and they screen with the platform impact 500 mutations to understand what exactly is the percentage of patients that are able to receive precision oncology in an academic center. And the answer is 37%. So out of the 10,000 patients, 37% as a result of doing the analysis of the genome receive a personalized medicine. But this ranges from GIST that you have up to 80%, cholangiocarcinoma 45%, but HCC in the bottom just 5%, because barely we have actionable mutations in HCC. Luckily enough, we know the molecular classification. The molecular classification in HCC, our group was the first. We published that. Dr. Daniela Sia reported that in Gastroenterology in 2017. And then we have recently updated the classification. And in short, we have 35% of inflamed tumors or hot tumors, and 65 of non-inflamed or cold tumors, among which 20% of those are immune excluded, or in other tumors they are called immune desert. So we assume, for understanding the pathogenesis of what's going on and the immune types of cells that are enriched in immune hot tumors, that the immune hot tumors are more prone to respond to immunotherapies. Let's see if this is the case. So let's talk a bit about the management and how immunotherapies are now modulating the management of this. This is the BCLC classification. We classify HCC in 5 stages. Mostly early stages are single tumors or 3 less than 3, and they achieve, with resection, transplant, and local ablation, 5-year survival rate of, or median survival of 60 months. So in early tumors, 60-month median survival. And in terms of resection, there are 2 approaches. The Western approach, that is what we're doing here, that we are more conservative. We are only selecting patients with well-preserved liver function and absence of mild portal hypertension, and undergoing resection, the mortality rate, perioperative mortality rate is 0.5%, with very low risk of decompensation, 5%. But there is the Asian approach that is much more aggressive approach, where they are operating tumors that are larger or multinodular, and they are able to remove 3 segments out of the 8 segments of the liver, and this leads to up to 30% risk of decompensation and 9% of mortality. And here you have a series of more than 2,000 resections, and in green you have those patients in which resection was indicated. Actually, the tumor was removed, and the 5-year survival rate is about 70% at 5 years. In blue, candidates for resection in which the tumor was not removed, they receive another therapy. The survival was significantly lower. And finally, in red, those patients that actually were not candidates for resection, but they actually received resection, will be more the Asian approach according to Asian guidelines, and the 5 years survival was around 35%. So what is the role of immunotherapy in this setting? There are 2 approaches, and one approach is the adjuvant immunotherapy, that is the more conventional approach, where the surgeon removes the tumor, then the treatment is applied afterwards, and then there is an activation of few different T cells, and fewer and less diverse T cells search for cancer cells. This is the actual approach. Then the neoadjuvant plus adjuvant is the, let's say, the novel approach that is gaining more momentum at this point. Why? Because when you have the tumor, when you have all the bulk of antigens there presented, and therefore it is the ideal place to deploy the immunotherapies prior resection. Then it gets, the cells get activated, many different T cells, then the tumor is removed, and then many more and more diverse T cells search for cancer cells. So, and then after the resection, you keep giving adjuvant therapy. So what study epitomizes the beauty of the neoadjuvant adjuvant compared to adjuvant alone? Melanoma, in this New England paper led by Tony Rivas in UCLA. So they compare neoadjuvant pembrolizumab plus adjuvant pembrolizumab compared to only adjuvant alone. But it's 12-month treatment, 2 resection and 10, or resection and 12 afterwards. And there is a significant difference in terms of the primary endpoint that was recurrence-free survival. So this this was a change in the view of what we have to do. And are we doing this in HCC? Yes. And one of the pioneers is the group here in Sinai with Tom Myron, Scott Myron Swartz, and Miriam Merritt. They developed neoadjuvant therapies. This is the case of cemiplimab, a single agent, and just to give 2 months of single agent prior resection, tumor necrosis above 50% was achieved in 35% of the patients. And then they study what was happening in this Nature Medicine paper. And actually, of course, they defined that the hot tumors were responding, but also an important message, there is a proportion of hot tumors that are not responding to single agent checkpoint inhibitors. And I will develop that concept later on because it is very important to understand why hot tumors are not responding. So then this is neoadjuvant. We are not there in HCC. Phase 2 studies. What about adjuvant? Well, we had, for 30 years, 40 randomized controlled trials, all negative. And in 2023, there was the first trial positive with atezolizumab plus bevacizumab versus active surveillance after resection and local ablation. And this therapy was given for 1 year. So, and as you can see here, hazard ratio 0.72 for the recurrence-free survival, p-value 0.012. The trial was stopped, was claimed this is a positive trial, published in Lancet and adopted in guidelines. Unfortunately, later on, it turns out that the follow-up of the data indicate that the hazard ratio moved from 0.72 to 0.9 and the p-value was negative. So how come a positive trial can become negative? And we have been studied that with some guys, my team here, and we identify that it's due because the non-proportional hazards, and if you are interested in that, we will talk about this later on. So actually, we do not have adjuvant therapy in the setting of HCC. Transplant, very briefly, because this is the same picture as 30 years ago, Milan criteria, boom, single tumor less than 5, 3 less than 3, outstanding outcome. Hundreds of studies, retrospective, prospective, fantastic indication. What about if we push a bit the envelope beyond Milan criteria? Well, there are a lot of different sizes and number of tumors. So the bottom line is that expanding slightly the Milan criteria, you still achieve median survival, 5 to 7 years, but you are increasing the recurrent rates to 20 to 40%. And recurrence in transplant doesn't happen as in resection that happens in the liver. In transplant, 50 to 60% of the recurrences are outside the liver. So by default, these recurrences are systemic, so therefore should be treated with systemic therapies, as opposed to after resection, most of the recurrences occur in the liver, so can be treated locoregionally. Well, here we were leading one of the, I would say, the best studies, led by Parisa Travisen from the Transplant Institute. She put together 2,500 cases of liver transplant for HCC, and we were analyzing the 3 scenarios. One scenario is the classical one. Okay, Milan criteria, single tumor of 3 less than 3, undergoing transplant, boom, 10-year survival, 61%, outstanding. What about downstaging? That has been debated a lot. If you get downstage the tumor, so it's beyond Milan, and as a result of locoregional therapies goes within Milan, the 10-year survival is 52%, which is pretty amazing. Conversely, if you are unable to downstage the tumor, then the survival goes down to 39% and recurrent rate 47%. So then in this scenario is more questionable. What about immunotherapies in this regard? Because liver transplant, because you are giving immunosuppressant, is regarded as a contraindication for liver transplantation. But in Sinai, we are pioneering the neoadjuvant therapy in the waiting list of transplant. And here I'm presenting the first 17 cases we recently reported. That is like a small pilot study, but this is the first one reporting a Josep in the waiting list of liver transplant. And just to mention that if you are performing locoregional therapies, you have partial response 62, complete response 13%. Look, when you are adding a Josep in those patients, then the complete response reaches up to 60%, and then this mimics what happens in the pathological report, that is a complete response close to 47%. So as a result of that, now we will be starting a phase 2 study using TARE, so Y90, because this is the standard of care, either TARE or TACE, plus a Josep in the waiting list in a pilot study with 40 patients. Well, another treatment is local ablation. The standard is radiofrequency microwave with a level 1 strong recommendation from ASLD. But in this institution, we have been working with radiation segmentectomy, and it got level 3 evidence because there are no randomized controlled trial, but a strong recommendation because the complete response is achieved with radiation segmentectomy ranges between 65 and 85%, which are very high complete responses. And the difference between the panel in the left and the panel in the right is that radiofrequency and microwave are very good for tumor less than 2. But once the size gets beyond, less than 3. Once the size gets beyond 3 centimeters, then the percentage of effectiveness decrease a lot. Conversely, with radiation segmentectomy and at the bottom with SBRT combined with TACE in this case, it's very effective in tumors above 4 centimeters. Well, let's move to intermediate HCC. Okay, for 20 years, chemoembolization has been the standard of care, but last month, 2 randomized controlled trials were reported combining TACE with immunotherapies, and I'm going to walk you through that. Okay, you have the conventional TACE, the drug-eluting bead TACE, that you are embolizing the tumors with beads that are loaded with chemotherapy and have a slow release of high dose of chemotherapy within the tumor that lasts for 7 days, but without systemic levels of the chemotherapy. This is very effective. Then you have the TARE, as I mentioned. So the standard of care comes from this meta-analysis we published in 2002 of 6 randomized controlled trials. At that time point, the median survival for intermediate was 20 months, and now is the standard recommendation. TACE is still chemoembolization, but also Y90, that is what is widely used in Sinai, mostly throughout the US. It's also strongly recommended, but with a low level of evidence because you don't have randomized controlled trials or meta-analysis of pooled data. So, well, we have the standard of care, let's say TACE. Can we merge that, combine that with TKIs and immunotherapies? Well, for 10 years, between 2009 and 2019, there were 10 randomized controlled trials combining TACE with TKIs, sorafenib, brimonib, and others. All the trials were negative. What we learned from these trials is the new standards for outcomes. The modern randomized controlled trial reported the outcomes of median survival 26 to 30 months, progression-free 7 and 8 months, and objective response 50%. Okay, but still, we're using a treatment that has been there for 20 years without a major advancement. Now, I'm showing you the Emerald one, in which they combine durvalumab, that is a checkpoint inhibitor, anti-PD-L1, bevacizumab, anti-VEGF-A, TACE versus TACE. And here, probably you cannot see that properly, but the hazard ratio is 0.77, p-value 0.32, positive trial for progression-free survival. Conversely, durvalumab alone doesn't make any difference, so the hazard ratio is 0.94. So bevacizumab is providing on top of immunotherapy the delta, either because of Beva has anti-tumoral effect per se, an immunomodulatory effect per se, with normalization of the vascularization and increase of T cells within the tumor. More interestingly, in my view, because I was last author of the paper, sorry, was lenvatinib plus pembrolizumab, but objectively, with lenva plus pembro plus TACE versus dual placebo plus TACE, this was a double-blind placebo-controlled trial with a double DUMI that is very difficult to do, and was run by Max Sun here in Sinai, has a ratio 0.66. So the other was 0.70 plus. Here is 0.66, p-value 0.002, and there is a substantial difference in progression-free survival, and is the first trial with a hint of an impact in overall survival. In the first interim, the hazard ratio was 0.8 and p-value 0.087. We reported that last month in Lancet, but it's the first time that we are showing differences in survival in a modern randomized controlled trial. Well, now, so we talk about early, neoadjuvant, adjuvant, intermediate, plus minus immunotherapy, but the revolution has happened in advance. So here we are, advanced, just to drop you two figures. 15 years ago, the natural history of HCC at advanced stage lead to median survival of 8 months. 8 months. Now, with all the therapies that we have, the median survival is up to 20 months. So this is, and I'm sorry because I was the first author, this is the breakthrough. Well, this is the most quoted paper in liver cancer ever. It's 12,000 citations at this point. So this is the New England paper. What's the beauty of that? We had no clue that this was going to work. I have to disclose that. But it's a multi-kinase inhibitor. It's a dirty molecule blocking 40 kinases. But the beauty was that it's the first time that you were showing that a drug, systemic drug, was better than a control, that best supportive care. And here you have the data. Doesn't look, I mean, for me, it looks very exciting, but if you are an oncologist, or it's very exciting, but if you are saying, okay, 7.9 month median survival, we're moving to 10.7, okay, looks good, but this was really a breakthrough. And as you can see, in 2016, this is a Nature Review Disease Primer we published in 2016. And as you can see, for systemic, we only have sorafenib. And sorafenib was there in 2008 until 2019. 10 years, nothing happening because all the drugs that tried to beat sorafenib failed. This is the most potent drug head-to-head to sorafenib. This is lenvatinib, a very potent multi-kinase inhibitor, also blocking 30 kinases, including FGF receptor 1, 2, 3, 4, BACF1, 3. And you can see here the head-to-head comparison. They have two watches, one for superiority, boom, negative, and then one for non-inferiority. So this is a smart design because they were able to rescue lenvatinib, and the lenvatinib got approval by FDA, EMA, and all the international regulatory agencies for the management of the disease. So lenvatinib, second drug in the field, and this was published, you can see Lancet 2018. So then in second line, patients progressing to these TKIs, we have regorafenib, cabozantinib, and ramucirumab. I'm not going to extend on that. These are TKI. Ramucirumab is a monoclonal antibody, only working in patients with FP more than 400. But let's move to the true meat here, right? So what happens, therefore, because this is the era, the period of TKIs, sorafenib 2008 up to now 2019, where immunotherapy is kicking. So these are the trials in frontline, most of the trials in frontline and in second line, in red, negative trials, in orange, non-inferior, lenvatinib, and in green, positive trials. I explained you sorafenib, and I explained you ramu, rego, cabo. But here we have three combinations with immune-based regimes that have been positive. So these are this is the second era of the systemic therapies in HCC. Okay, which immunotherapies? Well, you are familiar with the anti-PD-1, Pembro, Nivo, anti-PD-L1, Atezo, Durva, anti-CTLA-4, EP, Treme, right? This works in the lymph node, the others work in the tissue microenvironment. But now there are other drugs. Of course, you have LAG3 inhibitors, TGT inhibitors, TIM3 inhibitors, and so on and so forth. And the objective response rate ranges from Hodgkin's disease, 85%, up to down to hepatocellular carcinoma, 20% objective response with single agents. So the first two trials were a disappointment. And we were very disappointed because we are always behind the big four, right? Behind non-small cell lung cancer, behind colorectal, and in immunotherapy, behind melanoma. Melanoma is opening the field. Everybody's following melanoma. And here, these are the two first trials. One in frontline, nivolumab, boom, negative. Pembrolizumab, second line, negative. Objective response in both cases, 15%. Was a lot of disappointment. So it's not going to work in HCC. Well, the conclusion was probably we need combinations. Single agent, it's efficacious, but only targeting objective response in 15% is not enough to drag the effect. And second, eventually we need biomarkers of response. And I'm going to address now in this second part of my lecture these two scenarios. Well, why combinations and which combinations? I mentioned that 65% of HCCs are cold. They are very unlikely to respond to checkpoint inhibitors. So you need to shake these tumors. Per se, with single agents, they are not going to respond. First of all, because they don't have actually CD8-4 or CD8s in the tumor. They don't have T cells, so it's very difficult to activate the T cells if the T cells actually are not there. And all these drugs on top have immunomodulatory effects, not only anti-tumoral effects. Globally, some increase the dendritic cells, increase T cell infiltration, PD-1 expression, or N1 neutrophils, and others decrease MDNCs, decrease Tregs or M2 TAM, tumor-associated macrophages. So the combination of first giving this drug and on top giving immunotherapy look appealing because then you can switch cold tumors to hot tumors. And when the tumor is hot is when the checkpoint inhibitor can act. Well, the first study, this is the second breakthrough, the first study that demonstrated that was the IMbrave 150 combining atezolizumab plus bevacizumab versus sorafenib, 19.2 months versus 13.2 months. You see, so natural history 8 months. Now with sorafenib, we're moving to 13.2. With atezobev, we're moving to 19.2. Well, but another study, not combining with bevacizumab, but an IO, durva, and anti-PD-1 and anti-PD-L1 and tremelimumab, anti-CTLA-4, in combination, they were superior to sorafenib, hazard ratio 0.78. But recently, last year in ASCO, they presented the combination of nivo-ipi, also similar concept, anti-PD-1, anti-CTLA-4, and here you can see 23.7 months. It's not because this combination is outstanding, but also because more and more patients progressing frontline combination are receiving effective drugs, that is, these drugs are also improving the outcome. So it's around 50% of the patients in these trials are exposed to second-line drugs that are effective, and as a result, the outcome is improving. But now we're talking about 24-month median survival. Well, so what we're doing with all these drugs, and here we publish a summary based on the recommendations of guidelines, ASCO, ESMO, EASL, SLD, AGA, NCCN. So most of the guidelines and the scientific society recommend atezobev in frontline, particularly if the patients are not at high risk, because now an upper GI endoscopy is needed prior bevacizumab due to the risk of bleeding, right? So then if there is no high risk of bleeding, then atezolizumab is the preference, atezobev. If there is risk of bleeding, there are two strategies. One is treat the varices with carvedilol and banding, blah, 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 or move to IO, durva-treme, nivo-ipi. And then for those patients with contraindications, to checkpoint inhibitors, mostly with autoimmune disorders or liver transplantation, then sorafenib and lenvatinib are doing very well. In patients progressing to frontline immunotherapies, there is a debate because now we don't have trials, we have educated guess. There are no trials upon progression so far published. So the educated guess, some of the physicians in the guidelines are pushing to, after atezolizumab, giving nivo-ipi with the concept that the populations that respond will only some overlap, but others will be different populations of patients, and therefore is a justification to give IOI in second line. Others stick to the norm, okay, Lemba is working very well, let's give Lemba, and then upon progression to that, you have Revo, Cabo, and Rama. And finally, let's talk about biomarkers, because another strategy could be, okay, why don't we select those patients that actually respond to immunotherapies and how we can do that? Well, you can see these trials are showing a 4-year survival of 30%. So there is a proportion of patients that actually respond that have a very good survival, because these patients have a very poor survival, median survival of 8 months. Now 30% are alive at 4 years. And this is another trial showing that. And the reason is that they achieve complete or partial response when they are exposed. And these responses are long-lasting responses. Median duration of response generally with IO is maybe 20 months, which is a lot. So can we identify the responders to single agent, and more important, to combination of agents, in order to move the median above 3 years, 36 months? This was a dream 10, 15 years ago, to get 36-month median survival in frontline. So how we can do that? Well, non-small cell lung cancer, with pembrolizumab, they have a companion diagnostics that is the immunostaining for PD-L1. If it is positive in frontline more than 50%, boom, this is the indication. And in second line, more than 1%. Well, it's not working in HCC. What about tumor mutational burden? Tumor mutational burden works well with high mutational loads, defined as more than 10 mutations per megabase. And this barely happens, only happens in melanoma, lung cancer, or bladder cancer, but not in hepatocellular carcinoma. We have between 3 and 4 mutations per megabase. So tumor mutational burden doesn't work to enrich for responders. But we have the immune classification. So what if we are able to identify a signature that is able to capture the immune hot tumors? This will respond, and this has happened. So we have one signature published in JEP, our signature published in Gastro, and another signature reported at ACR. So there are already 3 signatures that are capturing the hot tumors and are associated with better outcome. And then also, we know that the excluded class is associated, and I will explain that later on, with some type of mutations of beta-catenin, also TGF-beta signaling, and so on. So can we use these tools to differentiate the tumors? Well, the problem is that while we are expanding our time in signatures for single agent, the field is moving to combinations, and already here you have the same concept. CD8 T cell density, T effector signatures as predictors of atezolizumab. Well, I'm going to show you our study with 320 patients treated with atezolizumab. Well, first of all, from a prior study with single cell sequencing, we were able to recognize close to 35 immune populations, and by using the transcriptome analysis, we generate gene signatures to recognize 21 cells, and we failed to recognize the other 14. But this was a very useful tool, because single cell sequencing is very tedious. You need fresh frozen tissue by the side of the patient. It's a very sophisticated analysis, and then you cannot translate that to real life. But we translate the cells into signatures, and as a result of that, when you have the transcriptome, then you can use that in large cohort of patients by doing RNA-seq, and we did that. And the first concept is what we knew. Look, if you had hot tumors, there is a percentage of hot tumors that are immune active, and here you have CD8 TEMRA, CD8 TEX, and macrophages CXCL10. These three cell types epitomize what is an active tumor. They will respond. These are classical immune responders. Okay, we recognize the cells, but not so much novelty here. Then we were surprised because immune cold tumors were responding to atezolizumab. How come? And we figured out that it's because they were responding to bevacizumab. They were mostly, and the biomarker that predict response is this receptor NNP1, and certainly those patients with high NRP1 did not respond to beva, as opposed that nothing happens with sorafenib, and here you have the P of interaction. So we had this biomarker that predict response to bevacizumab. And then the other interesting concept is that, okay, what about primary resistance? So you are giving atezolizumab, nothing happened to the patient. No response whatsoever. First CT scan MRI or second CT scan MRI, boom, progression. Median time to progression, 2 months, 3 months. Median survival 8 months. Terrible. These are very aggressive tumors. Something happens here. What happens? Well, we have two explanations. First, a percentage of hot tumors, and this was also in the paper of Maron, a percentage of hot tumors are not responding or whatsoever to immunotherapy or immunotherapy combinations. Why? Because they are dominated by immunosuppressive cells. So these cells are CD14 monocytes and TREM2 macrophages. These are the two types of cells in our study that were associated with lack of response despite hot tumors were there. And now we're doing spatial transcriptomics to understand the distance between these cells and the active cells, whether if there is a very close distance, probably these cells are able to inactivate the other cells and don't allow the other cells to actually attach to the antigens and kill the neoplastic cells. So this is an interesting message that goes aligned with what I mentioned before in neoadjuvant. And then there are other tumors that are immune desert. You are not expecting to respond to checkpoint inhibitors, but they are with very poor outcome and very aggressive tumors. And they are characterized in our hands by not signaling and TGF-beta signaling. That is a very potent immunosuppressive in the microenvironment, in the stroma. So this is our conclusion regarding the mechanism of action. So here I'm summarizing. So I don't know if you can see here, in yellow and in blue are the two types, immune active or angiogenesis-driven response. So some are responding to checkpoint inhibitors, the other to beva plus checkpoint, let's say. On the other hand, in purple, you have primary resistance, either driven by immunosuppressive cells or by not signaling TGF-beta signaling that are cytokines related to TGF-beta cytokines related to immunosuppression, and in between all the others. So, and I take advantage to this picture in order to explain you in this slide what I envision, what is the future of HCC in the next 5 years in my view. Well, first of all, so those patients that have that we can call molecularly based responders, so this 33% of the HCC population will have a survival of more than 30 months. So what's next for them? Well, they respond, so how we can improve that? Well, one is with triplets. Now we are running a trial here, and when leading this trial internationally, the IMbrave 152, atezo, beva, anti-TIGIT, based on the data of the Morpheus trial. And with this triplet, we think that this may even further increase the response, and the response will be more long-lasting. Okay, this is one strategy, triplets. Another strategy, because at one time point you keep adding triplets, but on the balance you have the toxicity, and the toxicity is a bottleneck. So there is a trial, the CARES trial, in which they have a combination, but the treatment-related adverse events, grade 3, 4 is 80%. Look, this is a red flag. You cannot accept grade 3, 4, 80%, right? So then when you keep adding drugs, at one time point, they will reach a ceiling of toxicity. Then it's the time for the biomarkers. It could be better to select the populations. So then probably then the industry will invest in, we have recognized the biomarkers, but the biomarkers are not approved because they need a specific path approved by FDA, and they are not investing in that. Probably this will be the way. What happens in the other side? Those tumors that are primary resistant to immunotherapies, well, what I envision here is we need new drugs, for instance, TGF-beta inhibitors or Notch inhibitors or Wind inhibitors, plus minus checkpoint inhibitors eventually, but certainly new types of drugs, or eventually cell therapies. We don't know if CAR-Ts or all CAR-Ts are in embryo phase in HCC, I have to say, and mostly in solid tumors, are effective in liquid tumors. But nonetheless, this could be another approach. Vaccines, there are some hints in HCC with a couple of papers, one by Icahn in Nature Medicine, suggesting that vaccines are able to personalize the vaccine to the antigens expressed in a given tumor. It's a very expensive approach, but eventually this can be an approach as long as you are able to neutralize the immunosuppressive signals. So this is what I view for this subgroup of patients. So conclusion, so the first thing is that the incidence is growing, 1 million this year. Risk factors, FC is decreasing, and MASLD is the fastest growing incidence and etiology. Molecular aberrations in HCC, unfortunately, are unactionable. Immune classification, we are lucky enough that we are able to decipher precisely the immune active and non-inflamed tumors and eventually associated with immunotherapy response. For early resection, transplant, and local ablation are there forever. Adjuvant treatments have failed. We thought that Josep was positive, but ultimately was negative. Neoadjuvant and adjuvant are the approaches in my mind that are more sound. In intermediate, we have chemoembolization as a standard, but now with these two trials just reported, probably the guidelines will change. Frontline advanced, we have immune-based therapies mostly, atezolizumab, durvalumab, nivo-ipi, and in patients with contraindication, we have mostly lenvatinib that is now more prominent than sorafenib. And in second line, either sorafenib, lenva, or even IO patients progressing to atezolizumab. And in terms of biomarkers, predictors of response to immunotherapies have been identified but are not approved. Gene signatures for single agent, and predictors of response, as I mentioned, or resistance to atezolizumab. So finally, I would like to thank the liver cancer program that now we're at the 20th anniversary. So we created the Scott Friedman that is here in the audience, Myron Swartz, and myself, and also Sam Waxman. We started the program in 2005 with 22 faculty members now, 7 labs. We reported more than 1,200 papers. We are the #1 NCI, the one and only, I have to say, NCI recognized program in the US, the first US referral center for HCC with 400 patients per year, with an annual funding of 5 to 6 million, NIH grant, now we have 9 R01s or UO1s, and certainly I know the world very well. I think we are the #1 program globally. So thank you very much to the program. Thank you.